Welcome back, everyone, to another explainer in our Decode Healthcare with Harshal series. I mean, can you believe it? We are officially at part 60 of our 100-part journey through the ICD-10 CM guidelines. Hitting this massive 60% completion landmark is just incredible, and we're celebrating by tackling one of the most critical, yet honestly frequently misunderstood areas of medical coding. We're diving deep into Chapter 19, which covers injury, poisoning, and certain other consequences of external causes, specifically looking at codes S00 through T88. Our mission today is crystal clear. We are completely bypassing those textbook simplifications and going straight to the ultimate source of truth, the CMS ICD-10 CM official guidelines for coding and reporting. Specifically, we're going to master sections I.C19A and C. These sections basically dictate the absolute laws for traumatic injury rules and those highly specific seventh character care extensions. So if you've ever felt kind of confused by exactly when to use an A versus a D extension, or how to sequence a patient who has a dozen different injuries from a major car crash, well, you are in exactly the right place today. All right, let's take a quick look at today's syllabus. We'll start with Chapter 19, S versus T codes, then move on to decoding seventh character extensions, active versus subsequent care, multiple injury sequencing laws, and finally, fracture defaults and the Castillo classification. Let's kick things off with Section 1, Chapter 19, S versus T codes. So when you open up this chapter, you're going to immediately notice a really intentional split in the alphabet. It's like a giant sorting system. Your S codes, those are your precision tools. They map to exact, highly specific anatomical body regions. We are talking about localized injuries to the head, the thorax, the hip, the wrist, basically codes falling anywhere between S00 and S99. On the flip side, T codes act as a bit of a catch-all. They cover systemic issues or areas that just lack specificity. So if an injury is to an unspecified body region, or if your patient is dealing with burns, frostbite, poisonings, or toxic effects of substances, you're going to be living exclusively in the T code section. Getting this structural baseline down makes navigating Chapter 19 significantly faster.
Moving right along to Section 2, decoding seventh character extensions.
In Chapter 19, almost every single code requires a seventh character to be valid. And honestly, this is where so many coding errors trigger claim denials. Let's do a little myth-busting right off the bat, okay? Does initial encounter actually mean the patient's literal first visit to a facility? I mean, when you see the word initial, it's completely natural to assume it means day one, hour one, the very first time that patient walks to the hospital doors. But in the world of ICD-10 CM guidelines, words have very specific, sometimes totally unintuitive legal definitions. So let's just destroy that myth right now. Character A, which is labeled initial encounter, is actually assigned while the patient is receiving active treatment for their injury. It literally has absolutely nothing to do with whether a new provider is seeing them for the first time. Active treatment includes things like emergency department evaluations, surgical treatment, or even a new physician stepping in to evaluate and treat the acute phase of that injury. As long as that treatment phase is actively happening, you use Character A. And yes, that applies even if that care spans across multiple different visits or even different facilities. Which brings us nicely to Section 3, active versus subsequent care. To make this perfectly clear, let's just walk through a standard 3-stage clinical timeline so you can mentally map out the patient journey. Say it's day 1. The patient is in the ER trauma bay, maybe heading straight into surgery. This is active acute care, right? So we assign extension A. Now fast forward to week 2. The patient has been discharged and they come into the outpatient clinic just to have their sutures removed. The active treatment is totally done. They're now strictly in the healing and recovery phase. This means we switch to extension D for subsequent recovery. Finally, jump way ahead to year 2. The original injury has completely healed up, but the patient develops severe post-traumatic joint stiffness as a direct result of that old injury. This late effect requires extension S for sequela. So to recap, active treatment is A. Routine recovery is D, and late effects are S. The absolute most crucial takeaway here is that CMS explicitly prioritizes the phase of care over the provider's timeline. This direct mandate from the official guidelines is your best shield against auditors. Think about it. If your surgeon evaluates a trauma patient on day 3 of their hospital stay, well after the ER doctor initially saw them, your surgeon still bills with an A. Why? Because they are still providing active treatment for that acute injury. Setting these side by side really shows exactly what distinguishes the active treatment phase from routine healing. Notice how everything falling under routine recovery, Things like cast removal, taking out stitches, a standard follow-up, or a checkup x-ray just to ensure a bone is mending properly. These are all maintenance tasks. They happen strictly after the definitive, active intervention is completely finished. The very moment you transition from actively fixing the problem to just monitoring it while it heals, you drop the A and switch over to D. And a quick side note, CMS specifically states that aftercare Z codes should not be used for injuries. You simply use the acute injury code and append that D extension. Let's dive into Section 4, Multiple Injury Sequencing Laws. So what exactly happens when a patient comes in with multiple traumatic injuries from the exact same accident? Chapter 19 has very strict sequencing laws that you absolutely must follow to paint an accurate clinical picture. You'll want to follow 3 exact steps to sequence your claims correctly according to the CMS hierarchy. Step 1, always sequence the most severe injury as the principal or first listed diagnosis. Step 2, carefully scan the documentation for any incidental superficial injuries. And then step 3, and this is where so many coders trip up, you must actively omit coding those superficial injuries if they occur at the exact same anatomical site as a more severe injury. This whole principle is designed to prevent claim clutter. By intentionally masking minor scratches and bruises, we allow the major trauma to take center stage. For example, if a patient comes in with a massive traumatic femur fracture, and the chart also casually mentions some abrasions and bruising on that exact same thigh, you absolutely do not code the bruising. The severe femur fracture completely overshadows it. Imagine this mapped out on a standard claim form. The major injury, that fracture of the right femoral neck, locks right into slot number 1 as our principal diagnosis. Meanwhile, the minor abrasion of the right thigh gets explicitly excluded per Chapter 19 rules. It's purely incidental. We really don't want it diluting the severity of the overall claim. And if you ever doubt it, this rule, right from the CMS guidelines, is your absolute law for omitting those minor incidental injuries. It gives you full permission and actually the strict mandate to leave those minor codes completely off the claim. Keep it clean and keep it totally focused on the true severity of the trauma. Finally, let's wrap up with Section 5, Fracture Defaults and Gastillo. We all know fractures require an incredible level of anatomical and clinical specificity, but let's face the reality of daily medical documentation. It isn't always perfect. So what happens when a fracture isn't specifically documented by the provider as being open or closed? When the documentation is a little vague, coders often panic or think they immediately need to halt the whole process to query the physician. While querying is always a great tool, CMS has actually provided a very strict, built-in default mechanism to help us keep things moving. Here it is. If a fracture is not specified as open or closed, you absolutely must default to closed. Write that down, highlight it, remember it for sure. Also, the guidelines specifically note that if a fracture isn't documented as displaced or non-displaced, you automatically default to displaced. Knowing these built-in defaults is literally a game changer so you can code accurately and efficiently even when the clinical notes are a bit sparse. Now, let's see what happens when the trauma is much more severe. When you toggle from a standard closed fracture to a complex open fracture, meaning the bone has unfortunately broken right through the skin, the coding requirements shift dramatically. For severe open fractures of the forearm, femur, and lower leg, CMS requires the use of Gustelow-Anderson classifications to assign your 7th character. So, instead of just your standard A, D, and S, open fractures utilize an expanded, highly detailed list of extensions like B, C, E, F, G, and so on. These specific letters directly reflect the Gustelow-Anderson classification system, which differentiates between a type 1, a type 2, or the massive soft tissue damage of a type 3 open fracture. It really highlights the incredible scale of specificity required for trauma registries, which helps track the true severity of the injury, as well as things like delayed healing, non-unions, and malunions. And before we finish up, just a very quick, absolutely crucial reminder. A valid code in this section must always have exactly 7 characters. If your base fracture code is only 5 characters long, but you need to append a Gustelow extension, you must utilize the placeholder X to fill that empty 6th slot. That ensures your extension lands perfectly in that 7th character position. Without exactly 7 characters, the entire code is totally invalid. Well, that brings us to the end of our deep dive into Chapter 19's traumatic injury rules and those tricky 7th character extensions. If this explainer helped clear up the confusion between active and subsequent care for you, please go ahead and hit that subscribe button, leave a like, and share this knowledge with your fellow revenue cycle and coding professionals. It helps the series immensely and spreads the knowledge. As we wrap up this major milestone 60th part of our series, I want to leave you with a quick thought for our next session. Are you ready to master burns, corrosions, and the highly intricate rule of nines? We'll be decoding exactly how to calculate total body surface area and sequence multiple burns in part 61. It's going to be a great one, so you definitely won't want to miss it. Until then, keep decoding, keep learning, and I will see you in the next explainer.